Hi, everybody. I'm looking to see how many people we have here. Hey, Amy. Nice to see your smiling face.
Hello.
Hi, Kim. Thanks for joining us.
Thanks for inviting me.
Yeah, you bet. Let's wait for just another minute. There's still quite a few people ding-donging into the meeting. Here's our usual housekeeping reminders. Lisa Tunley, are you here? Yeah, I see her.
You need something?
I was just going to ask if you're going to take care of the recording.
Yeah, it's already recorded.
Oh, okay. I didn't know that. Can you all see my screen?
Yep. Looks
Okay.
good. I mean, it's not in presenters mode, but we can see.
Yeah. I'm going to be turning it over in just a moment. I don't think David has joined us yet.
Here.
Oh, are you there?
Yep.
Oh, okay. Well, hi there, David. I can't talk about you if you're there. I mean, talk behind your back anyway. Okay. All right. Here's our agenda today. We're going to hear from Kim Parker from this program about early childhood mental health. And then we're going to hear briefly from Pilar Thanshade, if I said that right. I emailed her earlier this week and said, is this how do you pronounce your name? Pilar Thanshade, if I said that right. She's going to talk about situations where undocumented people might be able to get services. There are some certain cases. And then Dr. Bard's going to give us a couple updates, and then we're going to have a few programs who are going to share some information about their PDSA projects. Dr. Bard, was there anything you would like to say before we turn it over to Kim?
No, I think we're ready.
Okay, Kim, the floor is yours. Oh, you're muted.
Sorry, I'm trying to share my screen here. Get us.
Yeah.
All right. Can everybody see that okay?
Yes, ma'am.
All right. So can you all hear me okay? Sorry, minor technical difficulties on my end here.
Yeah, we can hear you just fine.
Okay. Well, good afternoon. My name is Kimberly Parker, and I work at the Parent-Child Center of Tulsa as the Vice President of our clinical services. I help supervise our therapeutic services, Safe Babies court team, and our infant mental health consultation, which is what I'm going to be here talking about today. So we have through a collaborative partnership, we have infant early childhood mental health consultation services that are available to MIECHV funded home visitation providers in Comanche, Muskogee, Oklahoma, and Tulsa counties through this collaborative partnership with those that you see here on the screen, the Oklahoma Department of Mental Health and Substance Abuse Services, Oklahoma State Department of Health, and then the 2 infant early childhood mental health training centers for the state are Sunbeam, which covers Oklahoma City and that side of the state, and then Parent Child Center, who covers more of the eastern Tulsa area, part of the state. And each of the 2 training centers, Sunbeam and Parent Child Center, each have an infant early childhood mental health consultant that is going to be available to support the home visiting programs. And with Sunbeam, it's Amy Klober. And with Parent Child Center, it's Callie Keith. Obviously, neither which are me, but I was the one available today. So I supervise Callie and I'm familiar with the program. So I will do my best to answer questions and share as much as I know about the program with you today. Right. So this is just briefly what we'll go over in this short little presentation. A brief introduction of what infant early childhood mental health consultation is, and what does an infant early childhood mental health consultant do, what it is not, some of the benefits of having this infant mental health consultant as part of a home visiting program, and then things to consider together between the infant mental health consultant and the home visiting program leaders before getting started. All right, so to start with, infant early childhood mental health consultation is a multi-level preventative intervention that pairs a mental health professional with those who work with young children and their families, such as a home visitor. And the goal is to help meet the complex needs of families and to overall improve the children's behavioral health and social emotional development. A short video here, if it will work, it may not. Well, it's not going to work. Right. I keep getting alerts that I have very poor video quality, so apologies. I think you all will have access to the PowerPoint, but it's just a 2-minute video that kind of gives a brief overview of what infant early childhood mental health consultation is. And the video just really highlights the importance of it being a relationship between the 2 providers. There we go. All right, apparently I should just not be doing anything technical today. This is going all over the place. Okay. So what does an infant early childhood mental health consultant do? As you know, home visiting is very, very hard work. And home visitors are witnesses to some really hard, emotionally heavy family issues and really challenging family dynamics. So partnering an infant mental health consultant program with a home visiting program, the goal is to really help support home visitors in meeting those complex needs of families who may be impacted by all kinds of factors such as substance abuse, mental illness, interpersonal violence, impacts of community violence. And so the goal is to really ultimately help support the home visitor in being able to think about and address those mental health issues. It also helps build just another layer of support within your existing home visiting models to address these additional areas of need. The ultimate goal of infant mental health consultation is to have a consultative stance, meaning to work side by side with the home visiting team to build and enhance the home visitor's capacity and in turn to build and enhance that caregiver's capacity to problem solve around challenging issues and parent-child dynamics going on. So there's a lot of misunderstanding about what infant early childhood mental health consultation is. So I'm going to just share a few things that it's not. Infant mental health consultation and reflective supervision, neither are personal therapy. It's consultation is focused specifically on the system and trying to support the system in addressing these behaviors differently. Reflective supervision, on the other hand, is more specifically focused on the experiences, the thoughts, the feelings, directly connected with the heaviness of the work that the home visitors are doing. And it's not traditional child or family therapy. Typical child family therapy focuses on a certain individual or child family issue, whereas infant mental health consultation is more widespread. It really focuses on enhancing the skills and abilities of caregivers and other providers like home visitors to empower them to address the mental health needs of kids in their care and support the overall emotional issues going on with families. It's also not a replacement for your regular program, clinical or administrative supervision. The goals of your regular clinical and administrative supervision remain the same, focusing on things like problem-solving issues, developing treatment plans, working with families, compliance with your agency or program standards, training needs. The goal of infant mental health consultation and reflective supervision within that is, again, to support the home visitor with the emotionally challenging pieces of the work, and really to have another lens to think about the cases through. So some of the benefits of infant mental health consultation, ultimately the goal is to help reduce the stress and the emotional load on the home visitor. The consultant gives home visitors a safe, non-judgmental space to really discuss those challenging situations and concerns about the caregiver or the children that you're working with. Also space to process and reflect on your own feelings about the work that you're doing. And again, in turn, the hope is that helps reduce stress, it reduces burnout and reduces turnover, and helps home visitors feel more effective in their work and increasing the joy and happiness in what they're doing. It can also really support progress on the different performance measures required in your programs, such as the percentage of primary caregivers enrolled that are screened for things like depression and domestic violence or child abuse and neglect concerns, as well as increasing talking about and screening for those children's behavior and developmental concerns and having more parent-child observations. But this just goes over in general what some of the qualifications of an infant early childhood mental health consultant is. Just so you know, the person that you would be partnered with is they're licensed as a mental health professional. They have infant mental health experience. They've had training in reflective supervision and additional training and skills and things like trauma, the impact of trauma on us, parent-child attachment, and things like that. So as we begin this partnership between infant mental health consultation and home visiting programs, there's just really several things for the program leaders to discuss together and hold in mind throughout this process. Really starting with discussing what the needs are of the home visiting program and where the gaps exist, and what supports do they want and need in regards to mental health services for the families that they're working with. You want to think about things like, are you in your particular program, are you concerned about turnover? Are you concerned about staff burnout? Are you concerned about increasing training on things like maternal depression or parent-child attachment, or even cultural sensitivity and trauma-informed care? So thinking again, what are the needs and the gaps in your program? What are you hoping for? And really an essential piece is building that collaborative relationship between the two programs, and doing that before there's a crisis. So really thinking now about how your program can facilitate a collaborative relationship. It could be having the infant mental health consultant join your team meetings once a month. It could be having them kind of put up shop in the workspace, once a week, where they kind of have their office hours there in the home visiting workspace. Just that relationship building piece is really important, so that the staff feel comfortable coming and talking to the infant mental health consultant. And then just another really important piece to think about is clarifying the role expectations. Infant mental health consultants can play many different roles, so you want to think about in advance what you want them to do to best support your home visiting program. And then also what that process will look like to connect the home visitors with the infant mental health consultant. Do you want them to go through the supervisor first? Do you want them to contact the infant mental health consultant directly? And then again, just thinking about what supports you want that infant mental health consultant to do. Some things that would be possible, joint home visits with the home visitor. And again, that has an asterisk by it because that would need to be discussed in advance and carefully considered. And obviously talking with the program supervisor if that's something they want them to do. And on this particular case, it could be the consultant providing the home visiting supervisors with support. And it could be case consultations, and that could be as a group with the team. It could be individually one-on-one with home visitors, or it could be the supervisor and the home visitor coming together for that infant mental health consultation. And then this is the last piece. I'm trying to wind up. I know I'm short on time. They haven't set the official date to kick this off. I think the target is May, but this would be the contact information for the two infant mental health consultants. And they will be setting up specific office hours, as you can see on here, when they will be available by phone, by email. It could be a FaceTime or Zoom call. And we've talked with our particular home visitors about having some in-person office hours where we would just, our infant mental health consultant, Callie, would just be in their office space to be available. So I will pause now and open it up to any questions, and I will do my best to answer.
Thank you, Kimberly. This sounds like a terrific service for home visitors. Does anybody have questions for Kimberly?
Yes, so is this something that is going to be provided for the grantors, I guess, right now and the future? Is this going to be paid by our funding source? Is that something that needs to be allocated in your own grant? And especially right now that we're writing it, I know that we have been at least 2 years doing this in our agency, and we doing it with Madison Clark. That didn't see her in here, so I just have a lot of questions how that's going to work. And in the past, of course, I mean, because of the limitation of money, we were just doing it with a supervisor. So anything that maybe the parent educator was bringing to them, they could consult with them. So can you tell us a little bit more of this? Is starting when?
Yeah,
answer that,
we've
Kim.
we've started, and the actual direct consultation is still in the planning phases, and that's, you know, right now, like, our program has already started talking. I see Kelsey and Lena on here. Our infant mental health consultant has talked with both of them and talked with one of the programs. So right now we're really in that relationship building phase where before we start, we want to get out and make sure that the consultants know what is needed by each of the home visiting programs. And it's separate grant funding that we're able to provide this service to you all. So it's not something you have to add to your budgets or anything that you're in. John, jump in if I'm
Oh, no, that's
correct on anything
So
on
this
this,
will be,
because I'm flying by the seat of my pants on that.
No, you're correct, Kim. So yes, this is all part of the MIECHV funding. Similar to the diaper banks, we're running the contract through OSDH. That contract will go straight to the Department of Mental Health, who will be providing these TAs for infant mental health consultation. And this will be part of our formula grant. So it's not an ARPA request. So this will be an ongoing project. It's not going to just be 1 or 2 years, kind of like the diaper banks at the moment. We hope to see this go on a long-term project.
But this is just for MIECHV. So if you have state funding, then plan it accordingly, I guess, the way we have done it before.
So correct. So right now, this is kind of like a pilot. If we see this as a success for the MIECHV side, we would look at CDCAP funds to hopefully see if we can expand it to state as well.
Thank you so much. I'm afraid we're going to have to cut off the questions here because we do have a full program. Kimberly, that was very helpful, and her contact information, her email will be in the presentation that will be emailed to everyone who's on this meeting. So you can follow up with her. Now I'd like to go to Pauler. Pauler, are you ready to present? Oops, you're muted.
Okay, I think here I go. Let me see if I can get my. Oh, here.
I can share your okay.
Okay, I think I have it.
Okay, great.
Let's see. So, did I get it? I just wanted to briefly. I'll try to go quickly. For undocumented aliens, that LASSO is required to provide citizenship status, a citizenship attestation to all the people that we service based on requirements from Legal Services Corporation, one of our greatest funders. And it's just basically them signing and printing their name, putting a date on there saying that I am a citizen of the United States of America. If they cannot meet that requirement, though, however, we do have other exceptions. Most of the exceptions that we have are usually like resident alien. They could have their residency, victims of assault, sexual assault, domestic violence, trafficking. They could also be married to a U.S. citizen or have a U.S. child citizen and be in the process of getting their residency. So as long as they have submitted their application and their process and it has not been denied, they could also qualify for services. This is a complete list of the exceptions, and it would be the bottom half of what I just showed you that has the top, I'm a U.S. citizen. The bottom half would be completed by LASSO staff, and it would be determining if any of those exceptions applied, which the top 3 include having to be an alien that has been in some kind of assault, domestic violence, trafficking situation, them or their child, or another qualifying family member. That's the top 3. The 4th one is what I mentioned, the resident alien status. Then it's married to a U.S. citizen, somebody that's been granted a refugee or asylum by the U.S. It's not somebody that's just now coming in and has applied. They have to have already had their court date and have been granted that asylum. The rest are less common. These are people who have been, the deportation has been withheld, but they're still here legally. When they're citizens of Palau, some Marshall Islands, some very specific countries, if they have been referred to LASSO by the Department of State under the Hague Convention, I've never seen that one happen. If they're here on an H-2A agriculture or H-2B forestry visa, that qualifies them. And one of the I've never even seen these, but whenever they've been here prior to 1980, they meet the qualifications as stated in Kickapoo Indian, very limited. We would also have to attach verification along with this document to show that they do meet that certain criteria. Let's see. But what if none of these exceptions apply to the person that you're wanting to refer over? I would advise you to make the referral anyway. And the reason for that is because only an attorney can make a determination whether we can assist that family. And because sometimes, depending on the issue, we can represent a U.S. child, U.S. citizen child, instead of the actual undocumented adult, such as, for instance, in cases of SNAP, daycare, WIC benefits, SSI, Social Security, Medicaid, IEP, or guardianship. All those issues, what they have in common is that there are rights or benefits that a U.S. citizen is eligible to receive. And for that reason, that U.S. born child, we can represent them in getting those rights or benefits that they're entitled to receive, regardless of the adult's undocumented status. The types of cases that we cannot represent a child on separate from the parents would be such things as evictions, divorces, custody, employment disputes, and any other thing that has to deal with a contract, simply based because the adult would be the person that would need to be represented in those types of contracts because a child cannot sign a contract. And quickly, I wanted to present you with a couple of scenarios, or actually three. In this scenario, a disabled U.S. born child with undocumented parents needs a guardianship since he's about to turn 18. Would LASSO be able to assist this person? The answer would be yes, because the adult, the U.S. born child is disabled, and this just actually happened. I would add in an additional stipulation that LASSO would want to actually, of course, the parents can be the guardians for this adult disabled child, but LASSO would probably recommend that they also involve or have as a co-guardian somebody that's here legally, somebody that has a residency, somebody that has a citizenship, just in case they were to be deported for any reason, that the child would not be left without a guardian. Okay. Scenario 2, an undocumented family is being evicted and they have an infant that's U.S. born. Can LASSO assist? In this scenario, no. Because like I said, the contract, the lease agreement was actually signed and made by the adult parent, not the baby. And therefore we cannot represent that family. Now, the same scenario, in scenario 3, undocumented family is being evicted and they have an infant, U.S. born infant child. But I'm adding something else. The mom has been physically abused by father and a VPO is being filed. Can LASSO assist? In this instance, yes, because mom is now a victim of sexual abuse or some kind of assault by the father. And once she files that VPO, that gives us the documentation we need. Of course, that assumes that the father is no longer part of the household, but that gives her, that makes her eligible under one of the situations, which is the very first one listed on here, an alien who has been battered or subjected to extreme cruelty, or is a victim of sexual assault, and domestic violence victims fall under that category. And in summary, yes, LASSO does have a citizenship requirement, but there are exceptions, and that may apply, and ultimately only an attorney can make that determination. Also, an attorney is the one that can determine whether the client, or in some instances, the client may who the client is. And in some instances, a child U.S. born child can be the client. So please send all your referrals to us and let our LASSO attorneys screen those cases to see if we can accept them, because they always will. If we can find a way, we can make it work. Thank you.
Thank you. And I'm glad you gave your contact information, and y'all are going to get this presentation emailed to you too. Now, David, before I turn it over to you, I had one LASSO related question that had come up that we haven't clarified. At this time, are only the Tulsa home visitors supposed to be using Unitas for referrals to LASSO?
That's a question for me, right?
Yes, it is.
Yeah, the answer is yes, only Tulsa. That's correct. Correct.
Okay, so
It's
if
not
you're,
that we want to prevent referrals happening to LASSO from the Oklahoma County offices. We would just prefer that they use the traditional approach.
yeah, so if y'all are not in the Tulsa areas with the PDSA focus on LASSO, you can make referrals to LASSO, just not in Unitas. And so that question had come up and I wanted to clarify. I think we have time for maybe one question.
I have a question.
Okay, Cynthia.
Pilar, I actually sent 2 referrals. I want to say maybe the last month or 2. And we've received letters from legal aid that unfortunately you guys don't have enough attorneys. Can you give us a little bit of information about that?
Yes, the MIECHV website that I would encourage you to use is under, I just put it live. So prior to today, you were not able to refer to our grant, the Innovations MIECHV page. What you were doing is you were referring to LASSO, the general, and they will have requirements such as income, do they have the capacity? So you actually did not make the referral with the specific grant. You made it under the LASSO umbrella, general umbrella. So they treated that referral like anyone else. If you could give me those names or resubmit them under the, I don't know if that would mess up what David and what you guys are trying to capture. But now that I would encourage all of you to please be very careful in using the correct the page so that we do not have this issue again, because they will send them through the regular process. And yes, it will send them a letter that's lack of resources, saying we do not have enough attorneys, but LASSO does have the attorneys specifically designated for this grant.
Thank you, Paula.
Yes, thank you. And to the question of whether it messes up what we're doing, I would say no, not right now. We don't have Unitas connected. So for Tulsa and Oklahoma County, if you're making referrals, please make it through the web portal that Pilar has just mentioned. Once we have Unitas connected for Tulsa folks, start with Unitas. And then from there, you may need to use that same web portal, but we want the information in Unitas so that it can facilitate the bi-directional flow of information between you and your LASSO provider.
And
That's just for Tulsa right now.
So Pilar, the link or the place that we need to send them, that's not directly with Unitas, right?
It is through Unitas, but LASSO has a page that's for anybody, like general page for LASSO. You need to scroll further down in it until you find the program that says MIECHV or Innovations and file it under that program so that I can get that. Right now, I have actually 2 referrals that I do not know whether they're MIECHV or not. One is from, where did I write it? Community Health Engagement. I don't know. And the other one's from Creoaks Catoosa Clinic. So if I can identify those as potential from coming from you guys through the MIECHV program grant, I'm going to send them through the general LASSO application. And again, those requirements are stricter than our grant requirements.
Okay, thank you very much. And
I have a question
Paula,
because it's not that clear with Dr. Bart. So you're saying if we have a client, we cannot send it through Unitas right now if we're in Oklahoma County, but we can do it if we just get into their website and just go down to MIECHV?
Correct.
Or just email me their contact information and I will reach out to them and do the intake and route them through the MIECHV to our attorney.
thank you, Paula. You've just been a terrific partner through already. We really appreciate it. David, you have 10 minutes. The floor is yours.
Has anybody ever noticed what a great taskmaster Lisa Deshays? Okay,
I'm not shy.
I'm going to get under her skin here just for a moment, but Pilar, there was a message in the chat about posting a link to that website. Do you mind putting that up for the others to see? Okay, I'm supposed to be talking about in my 10 minutes the crossover my mobile health study, the parenting app study, and I just have a really brief update. And I'm going to share my screen when I do this. Okay, so the update is really just a count of participants to date. I will tell you that the recruitment is still open. So those of you participating, we're still interested in enrolling more clients into the study. We're about halfway to our stated goal for the funding sponsor, and we were actually trying to exceed that. So we still have a long way to go to meet the original target. So we're anxious to get some other programs involved. We've actually extended an invitation to some additional programs not involved with the collaborative, and we're hoping to recruit from those programs for over the next month. First table that you see, this is the progression of each of the participants to date. As you may recall, participation with the app lasts for 4 weeks, so essentially 1 month. And you can see that we have 4 relatively new participants who are involved in week 1 of participation, 1 currently involved in week 2, 2 in week 3, 4 in week 4. There's a period in between week 3 and in between week 2 and week 3. So when this report was run, somebody actually landed there. In 1 more day, they would end up in week 3. But that's the routines week 3 that you see on the screen. The 7 NAs here, I think most of those are actually complete. A little later down in this report, I might contradict myself, but I believe those 7 are participants who made it through all 4 weeks. 9 participants in the crossover study. Let's see, remaining 10 in the crossover 2 group. Oh yes, okay. So in the crossover study, we have 2 separate conditions. They either get the parenting tips right away, and they get those for 2 weeks. And then in the last 2 weeks of their participation, they no longer get the parenting tips, but all the while they've been getting daily this survey. We call it the EMA survey. The survey is about the parent engagement with the child over that 24-hour period. The other condition is just the opposite. For the first 2 weeks, all they get is that EMA survey. And then in the next 2 weeks, they get that EMA survey, but they also get the parenting tips. So crossover 1 is parenting tips in the second 2 weeks, I believe. And you can see that we've got 9 participants there. Crossover 2, you're getting the parenting tips in the first 2 weeks, and you can see we have 10 participants there. So it's highly balanced by intention. Your assignment to those conditions is randomized. We're pleased to announce, and all of you know this that are participating, that we have been enrolling Spanish-speaking clients, and they tell us up front if they prefer for the interaction to be with us for the assessments and such, and also with the app to be in Spanish. So we've got 7 total Spanish-speaking clients who are engaging in the study in that way today. These are the 7 that, and again, I think this is a mistake here, but I think these are the 7 that are completed. So we've got 5 in the crossover 1, condition 2, and the crossover 2. Engagement. So it's one thing to participate in the study. It's another to actually follow through and do those surveys daily, and then actually look at those parenting tips. This all gets tracked in the parenting app. So we get to see that, and we create reports on the back end. This is a very brief summary of that information. And we're just looking at the surveys. How often do they complete the surveys? You can see week by week that very few of them are not doing this. And in fact, if you were to tally all of this up, about 60% of the time that a survey shows up, they're completing it. So it's not perfect, but we didn't anticipate it to be perfect. And it's quite demanding to ask families or participants to do this every single day. So it's not uncommon. They're going to miss a day here and there. So 60% is where we're at. This is just a look at what the data behind the scenes kind of looks like. You can see every week and day, in fact, you get an indicator of whether they read the tip and whether they were notified and then completed the surveys. When we look at the tips, the engagement has been a little bit lower. There's a question out to the team that helped calculate these figures. I think that this is underrepresentative of the engagement with the tips. And I worry it's not counting, it's counting all these weeks, all 4 weeks, even though 2 of those weeks, they're not getting tips. So it says 30% here, but I would be shocked if it's that low. I think based on what I've seen in the past, it's closer to 60%. And I'm sorry, this is hot off the press info, so I couldn't get it revised in time to share that with you today. But I will email out the 4 groups that are participating a cleaner version of this sometime later this week. Compensation. So they get compensated for their participation. Every time they complete one of the surveys, those daily surveys, they get $2. We do not incentivize the parenting tips, since that is the focal intervention that we're paying attention to. But they do get compensated for a pre-intervention assessment that takes roughly an hour to an hour and a half. When you count the consenting process in there, most of that, believe it or not, is the consenting process. That takes about 20 minutes, 25 minutes to complete. So it's about an hour assessment, and they do get compensated for that on the front end. And then there's an hour assessment on the back end as well. They get $30 for completing each one of those. So this is the distribution of payment to date. Some of these are lower than the $30, and that's because they haven't completed one of these assessments yet. We've got some that are just getting started that are represented here, and others who have been involved from beginning to end who received a much higher payout. So
Is that $1 per participant?
these are $1 per participant. That's right. So this is the
Okay.
payout amount over here on the left-hand side.
Okay, thank you.
Okay, that's the brief summary. Any questions about the in-house study? Outcomes were remaining for a later date. We're going to begin taking a peek at that this week, and this all wraps up middle of May, end of May, I should say. Sorry, end of May. So we'll have final outcome results for you, I hope, at the June monthly call. We might take a sneak peek at it there. And if time permits, we may squeeze in some more in-depth review of the findings from the Parenting App study at the learning session in July.
So Dr. are you gonna send us who is ending? So I know that that was more in the trial. One of the families, the phone was not removed from her, and she continued completing this, and at the end she was not compensated for all the time that she put in. So I would like this time to have exactly who's ending, if they have the phone, when they're gonna take the phone. So at this moment, I don't know who's participating or not, who's active or not. So if you can send me that, that would be great.
Yeah, I can send you what we've sent in the past, where you can see who was referred to us, how many we were successfully able to contact, and then how many enrolled. I don't think I'm allowed by IRB standards to tell you how much compensation they got, but I can tell you whether they did get compensated. Because the compensation, you know, in part tells you also how extensively they engaged in the consenting process. We promise or commit to not share that information with others.
And if I understood you correctly, if the agencies have parents who may still want to participate, they can be referred for this study still.
The desperate to still enroll some participants. As I said, for the funding agency here, we're on the hook to try to reach 40. So we're only halfway to the 40 point. So we're hoping to double down our efforts by including some other programs in the next month, and still eager to enroll any other participants you might have that are interested in working with the app.
Thanks, David. Were you going to talk about the innovation project?
I'm going to pass that baton to Andrea, and I'm going to say a few words about it as we go. But so the innovation project, and I know in advance that the lines are blurred here. We talked about this a little bit in the past. I don't think the distinctions matter a whole lot for purposes of the collaborative. But the Unite Us piece is part of a separate project. It's not part of the mHealth project. It's not part of what we often call the MIECHV evaluation project. It's also happening at the same time. This is the one focused narrowly on the Unite Us connections with our referral network partners, and it is also the focus of the topic of this learning collaborative. We were tasked for that project with creating a baseline report of how the home visiting programs, how your home visiting programs have been engaged with our referral network partners traditionally. So leading up to today, what does it look like when you encounter a client who has a substance use concern, or who has a legal concern, who has an early intervention concern? How many of those get referred to services? How many of those do we have documented indication that they receive those services? So Andrew, do you mind flashing on the screen the baseline report dashboard that's being constructed? This is an evolving process. We do have a report that's due at the end of next month. It's a self-imposed timeline, but one that we'd like to keep. So this is the early makings of that report. There'll be a narrative version of this to go along with the figures you're seeing today. One of the reasons I wanted this to be on the agenda is we have some questions for the group about whether we're being exhaustive in our search for historic referrals to those broad categories I just mentioned: legal aid services, or legal needs and services, substance abuse services, and I would say developmental services broadly, not just early intervention. So on the screen, you see what ought to be a little bit familiar, the old line plots. And each line here, Andrew, I'm going to have you walk us through this. You want to interpret each line and what the X and Y axes mean.
Yeah, absolutely. So what we're looking at is the count of referrals to legal assistance across time. So on this X-axis, we've got the specific calendar year. Y-axis is the total count of specific unique referrals to legal aid services that we have record of on ETO. Now, at the moment, this is based entirely on the referral tracking touch point. So we go into that touch point. We look at, there are a couple of items that I'm sure this is familiar to all those data vectors here, but there's that referral out tracking touch point where you select a general category, then a specific category. Here we're looking at in the category of referral, there's an other category. If you select that, one of the options is legal services. And I'm looking at legal services specifically. So they must have been a legal service, and the service status on that referral must be in one of these categories. So an initial referral, a subsequent referral, the service is initiated or ongoing, referrals made, but the client just hasn't taken any action, or the client is waiting to receive service. Now, each one of these individual thin lines is a specific program across time. These gray lines here, there are actually 3 of them, but they're all kind of mushed together across time. Those are the model-wide averages across time. Oh, and one more specific detail for all of these graphs that I have. The subset, we've got a subset of data, which is families with a child that has been below an ASQ cutoff. So for each family where they've taken ASQ and at some point the child's been below a cutoff or at risk at one of these subscales, we identify that point in time and we just look at referrals to legal service that came in on that point, on that day or afterwards.
I have to stop you there, Andrew.
Yes.
And that may be just a confusion in the way that the task was assigned, but you're not looking at the ASQ with regard to the legal services, are you? Just for the referrals to Sooner Start.
At the moment, I have that filter is applied to the entire data set, which the one data set that all these graphs are based on. I can go back and change that if that's too restricted for the legal services.
It is for both
Okay.
legal services and for substance abuse. We want the whole client population to be included in those.
Okay. Yeah, I can do that.
So these lines are in numbers that they represent are going to grow a little bit when we include that whole client population. I think the main
Yes.
objective today was to explain how legal services is being defined with reference to the documentation in ETO. So Andrew briefly touched on that. I don't know, I'm sure how specific we can be here, Andrew, but when you look for an indicator of a referral to legal services, what exactly does the category say in ETO?
The exact text on ETO is legal services. There's a yeah, on the ETO touch point, there's a list of kind of general categories, one of which is labeled as other. If you click the radio button for other, you'll get a another list that is a little bit more specific. And under the other category, sort of sub list, one of the options reads legal services. And that's what I was looking for to find an indicator of a referral for legal services. So this isn't LASSO specifically, it is anything that is a legal service.
So for sake of time, instead of opening up the microphone to all of you, if there are other ways that you document referrals to legal services, can you put that in the chat for us so that we have record of it? And we'll make sure that we change the way we define that for these reports. Can you quickly show the similar report for substance abuse services?
Yes. So this is the same graph for substance use. Again, it's that same subsample. It's just those referrals for a family that with a child that has below the an ASQ cutoff score. And it sounds like I need to adjust that so that filter doesn't apply to these graphs. So I'd expect these numbers to jump up a bit. But for here, we're looking at, again, that same touch point, the referral tracking touch point. We're looking for kind of referral was set to either alcohol treatment, drug treatment, or smoking cessation. So referral to any one of these three was lumped into this one indicator for referrals to substance use assistance.
So again, to make sure that we're accurately and fairly representing all the historic referrals for substance abuse concerns, will you put in the chat any other way that those referrals might have been indicated that we're not capturing by focusing on alcohol treatment, drug treatment, or smoking cessation? I'm going to skip the last one because we've talked about that one ad nauseum, going back to the last one. But I think we're on top of that. We're using all of the information you provided previously to identify those developmental service referrals. We can come back and visit this in a month when we have an even more complete version of this dashboard and just double check those codings. But the two I was most concerned about today are how we're capturing legal aid services, historic legal aid services referrals, and the substance abuse concerns.
Okay, thank you. Can we go on to the next thing?
Yes, right.
All right, let me just share my screen real quick. And Dava, you're up first to talk about C1 and your PDSA.
Hi, so C1's PDSA has to do with LASSO referrals. Our nurses did have a meeting and came up with a screening tool that they're going to present to all our families to see if they're in need of legal services and if those legal services are captured by LASSO. This is our PDSA. So Smart Aim, out of the mothers with legal concerns, 100% will be referred to LASSO. The outcome will be percentage of mothers with identified legal concerns will being referred. Process measure percentage of active mothers assisted. And disruptors might be the percentage of mothers who refuse the assessment, percentage of mothers with an identified concern who refuse legal aid. Let's see. Anything else?
Where do things stand for you on Unitas and using it?
So we have Unitas. We make referrals in Unitas to multiple agencies. So our nurses are very familiar with that. So.
Okay, terrific. Thank you.
You're welcome.
All right. And next, Amy, to talk about Frontline.
Sorry, I couldn't unmute. Yeah, we are finished up our Smart Aim, and we are going to be partnering with with the Unitas to send referrals to Sooner Start for any suspected delays that we identify off of ASQs. We are just getting ready to launch with Unitas. We've registered. We have gotten set up. We're using our office coordinator is going to be our person of contact to do the referral process, and we're just ready to get started next month.
Okay. Would you like to step us through your Smart Aim and your measures?
Sure. So the Smart Aim, we're going to send 100% of the children identified during the ASQ screenings during their review process, refer them through Unitas to Sooner Start. Our outcome measures is the percentage of children with an identified concern and delay will be referred to Sooner Start through Unitas. And we're also going to measure the percentage of children who scheduled intake with Sooner Start. During our process measure, we want to measure the percentage of children with a visit during the review period who receive the ASQ screens. And some disruptors that we've identified is that maybe the parents will refuse a screening because that is their option. And the parent of the child who may have a developmental delay may refuse the referral. And then also the percentage of parents that just refuse to receive the service through Sooner Start are some that we've already considered. So that's kind of where we are.
That's true. That's great. Thank you. And now Jade for North Cares.
Hello. So we're going to be focusing on Sooner Start through the Unitas platform for our project. We're going to be looking at trying to get to our SMART aim of 80% of children who have those identified need for referrals, that they are connected with Sooner Start, but also that most of the family interviews with Sooner Start will also have a home visitor present. So we're going to be looking to see if it's going to increase kind of the likelihood that families stay with Sooner Start to complete the services with them, if we're helping kind of like with a warm handoff during that first visit with Sooner Start. So our outcome measure is going to be the percent of family interviews with Sooner Start have a home visitor present, and that the percent of children with an identified need schedule that family interview. And then, you know, we have our possible disruptor measures there listed out, but we're excited. We're excited to see how it's going to look.
Okay, great. Thank you. I think that's an interesting twist on it too, to be looking at that warm handoff. And I imagine a lot of programs are going to be interested in following up. David, we have 2 minutes left. I'm sure you can fill it.
Yeah, I'm going to come back to my questions from earlier. So with legal aid services, again, putting that baseline report together, one of the things I'm fearful of is we're not exhaustively capturing areas that that might have a different category in ETO, like housing evictions. So a referral may have been made to help a family work through a housing eviction. Legal aid services or legal services were not selected in ETO, but housing was selected. So if that's a common thing that happens, will you shoot me an email and maybe a 1 or 2 sentence explanation of those types of blurry distinctions that might be showing up in ETO. Again, the goal is to just try to accurately reflect historically how engaged have home visiting programs been with service partners who address legal services broadly, substance abuse services broadly, and developmental services broadly.
Is there anybody else who has anything that they need to ask or say? All right, we're done. We did it. We galloped like horses through this one, but I hope you enjoyed it and that you got a lot of good information. And we will see you next month for some rounding calls in another monthly meeting. Thanks, everybody.